This is an overview of Chapter 7. Chapter 7 is the economics of healthcare. So in this chapter, we're going to talk about the improving health of people in the United States, healthcare around the world, information problems and externality in the market of healthcare, and the debate over healthcare policy in the United States. Many of you taking this course are potentially healthcare management students, and if you're not a healthcare management student, you're still personally affected by healthcare, the Affordable Health Care Act, and the general cost of healthcare. So, healthcare expenditure in the United States is higher than any other place in the world. Why is this the case? So, why might healthcare be higher as a cost than any other place in the world? There are many reasons or potential ideas for this. Some of it could be our lifestyle. So we know that we are very potentially obese as a population, so that could cost. Another one is just general age of the population. The baby boomers, who is a much larger group than the group behind them, are getting older, so that could drive up the general cost of healthcare in the United States. Another reason is medical advances. So there's a cost to having medical advances. The things that you can do in the United States, you might not be able to do somewhere else. So, malpractice insurance is another reason. So, high quality of the healthcare is a reason. The system for payment. So, in this healthcare system, we're going to review different types of healthcare systems around the globe, and there's different types of payment setups, and that could be the reason for the cost. And it could be that there's higher demand for healthcare. Again, those things go back to lifestyle choices, population, the average age of the population, all of these things potentially, or healthcare is what we call a normal good. So think back to the supply and demand chapter. A normal good, as income rises, which it has in the United States, we might demand more healthcare. It's a normal good. In this chapter, we'll address some of the elements of healthcare that make it a rich field of study for economists. Okay, so improving the health of people in the United States. So we're going to just discuss the trends over time. The last couple centuries have brought incredible advances in health outcomes for Americans. So, in 1850, the average life expectancy at birth was 38.3 years. In 2011, if you were born in 2011, your average life expectancy is 78.4 years. The average height for males in 1850 was 5'7", and the average height for males in 2011, is 5'9" tall. And as you can find out from reading this chapter, it talks about how the height increases with an increase not just in genetics, not just a genetic thing. It's also has to do with your nutrition. An infant mortality rate. So this is the death of a person age 1 or less. It was 229 approximately per 1,000 live births, and it's 6.1 today. So why can this be? Why do we have such a longer lifespan now? Improvements in nutrition, public health movement. So as it's discussed in this chapter, we went from agriculture, we moved into cities, but originally we didn't do things like take out the trash or do things because now we understand that it's mostly caused by bacteria. So improvements in sanitation, improvements in food distribution. If you're eating bad meat or bad things that weren't refrigerated in the 1850s, then that's a problem. But now we have things, the clean water. All of these things matter in our health. The most dramatic gains have occurred in the 20th century. So 1900 and beyond. So life expectancy was 50. It kept increasing. It went down because of the 1918 flu epidemic. And then it has steadily increased all the way till now. The death rate. These are corresponding death rates. So our life expectancy is going up. The death rate is going down. So why is the death rate falling? Number one, medical advances and in prevention and treatment of reducing healthcare. So, there's been so many medical advances. So before, it used to be if you got, the flu, you wouldn't survive potentially. But now we have medications, we have vaccines, so smallpox and all of that. We have vaccines for that. Just recently, measles, things like that. We've seen a big increase in California. And so California has stated that if you want to come to public school, you need to be vaccinated because this not only prevents you, but it prevents you from spreading it. So advancements in treatment, so preventative treatment. And the other thing is life-sustaining activities. So we can treat cancer. We can do these other things. We can treat, it doesn't mean that everyone survives, but it just says we have a much better rate at that. So notice in the particular falling death rate from cardiovascular disease. So this is the death rate for 100,000 people. So cardiovascular disease. Why? Because as medical advances happen, we understand more what causes this, so we can do preventative and also how to treat it. You can get valve replacements. You can have a heart transplant. You can have a liver transplant. As you can see, it's been a steady line with cancer. Actually, it's about the same. But you have to figure that as we treat some of these things evolve. However, the deaths due to obesity-related illnesses are on the rise. And this is because we have so many choices and potentially poor nutrition in the United States. And it's not because we don't have access to food, but it is more expensive to buy healthier food. It's much cheaper to buy a soda or a burger than it is to buy apples and things like that, fresh fruit. So, this plays into it. So these are the diabetes and kidney diseases. And we noticed that that was a problem, and we're starting to address it, and you can see the trend is trending a little bit downward. So while incomes have certainly risen, health economists suggest that better health causes better incomes, not the other direction. So the idea that the income is causing better health is really the opposite. They believe that better health is causing better income. So what's the causal relationship between economic well-being and the health is not completely settled. So again, we're not really sure if more income, higher incomes causes better health, or better health causes higher incomes, or how it's really related. And some would say that we have our access to income has risen so much that we have all this opportunity to eat out and eat at all these places and do those things, and technically that has caused us to become more obese. We have all these advances. We drive around in cars, we sit at desks, we do computer work, we don't do any physical labor potentially, or physical activity during the day, and so also a cause for obesity. So an increase in national income allows for higher expenditures on research and development. This is also the case. We spend a lot of money here in the United States trying to come up with new medical advances, new treatment, cures for diseases, cures for ailments, preventative things. So this is a fruitful area for future research. So let's talk about healthcare systems around the world. I frequently hear this in all kinds of classes and debates, that other people have better healthcare than us. So let's talk about it. Most healthcare services in the United States are provided by private firms. So this means businesses are trying to make money doing this. But you have a different factor here in the United States. Payment to those firms generally comes not from the consumer directly, but through health insurance. Health insurance is a contract under which the buyer agrees to make payments or premiums in exchange for the provider agreeing to pay some or all of the medical bills. 49% of all health insurance in the United States is employer provided. 5% is individual. The majority of Americans have private health insurance. Then we have 17%, which is Medicaid, which is Veterans Association and other. So this is government provided. And then Medicare, this is if you're over 65. This is if you're in a special medical situation. Medicaid is for disability. Veterans are for people who have served the country. And then 17%, according to this, in 2009, are uninsured. So 1 in 6 Americans at this point had no health insurance. So insurances can take the form of fee-for-service, where the doctor is reimbursed directly for their services, or a health maintenance organization, where doctors receive a flat fee per patient. So this is, they bill a set amount, fee-for-service, or HMOs, they receive a flat fee. Compared with the rest of the world, the United States has a higher portion of its population uninsured. Why is this? Some people can afford insurance, but they elect to go uninsured and pay for their expenses as they incur them. Why? So if you're a recent college graduate and you're 22 years old and you're healthy, but they want you to pay $4,000 out of your pocket for health insurance, and you say, I'm going to go to the doctor's twice, and you can go down to Doctor's Express, you get a cold or you get some situation or you injure your ankle or something, nothing major, and you can go in there and pay a couple $100 and be done with it. Others cannot afford health insurance, but if you cannot afford health insurance, it's very likely that you can get onto the government health insurance. So what they do is when they need care, they generally either go without it or use a reduced price or fee for free services. The federal government's health care legislation enacted in 2010 was motivated in part by a desire to reduce the number of uninsured Americans. So Canada, I frequently hear our health insurance compared with Canada. They have what is called a single-payer healthcare system. Healthcare is provided by private firms, but paid for by the government indirectly via taxes. So basically, the government pays for all of the health insurance, but businesses provide the services in Canada, but it's all paid for by the government. So everyone has quote-unquote healthcare. In Canada, the individual pays nothing out of pocket. So you just show up to the hospital or the doctor, and you have the surgery. And that's it. Single payer healthcare system. No cost to you. But there is a cost to you. It's through taxes. Remember, there's no such thing as a free lunch, right? Japan, universal health insurance. Every resident is required to enroll in a not-for-profit health insurance society or enroll in the national government's program. So they have not-for-profit health insurance or the government. Individuals have substantial copays. So you have to enroll in the insurance, and then you have substantial copays. What happens when you can't afford these? I think that you get some sort of subsidy through the national government. In the UK, they have what is called socialized medicine, where the government pays for and provides all healthcare services with negligible copays. So in the UK, you pay like $5, and you show up and you get this service. So it's not a lot of money, but it's all government owned. So in Canada, private firms provide it, but are paid by the government. In this one, the government-owned hospital. Some people have supplemental private insurance in the UK, approximately 10%. So in this case, they can go to different doctors and things like that, or different services are available to the people that have private supplemental insurance. Healthcare spending per person. And this is the income per person and healthcare spending per person. As you can see, in the United States, healthcare is a normal good. The higher the income, the higher the expenditure. But we are significantly above this line and the trend. As you can see, the other countries are all around this line. We are above it. Why? Maybe we, as a society, are more cautious. Maybe we want preventative treatment. Maybe it is that we want extensive treatment. But the United States spends more per person on healthcare than any other country. By comparing data, it appears that Americans get a bad deal for its high expenditures. So, Canada's life expectancy is longer, and their infant mortality rate is lower. The other thing the problem with figures like this is you're not always taking into account, not everything can be compared. Potentially, we are saving preemies, so there's a higher rate here that maybe they're not saving in other countries, or maybe they're not attempting to save, so they might not even be live births. The obesity problem. Obviously, we are higher people with diabetes, so again, this is related to the obesity problem. Some would ask, does health insurance cause obesity? So here's the problems with comparing health across countries. It's often difficult and misleading. There are data problems. Many countries do not collect data in the same way, so we're not comparing apples to apples. Problems with measuring healthcare delivery. Quality of care is hard to measure. So you're measuring that they live longer, but what's the quality of care, quality of life? Lifestyle choices. Obesity and diabetes, for example, may have more to do with the choices of the consumer than the effectiveness of the healthcare. I mean, you could go to the doctors and they're telling you don't do this or don't do this, and you know what you're supposed to do, but you choose not to do it. Also, problems with determining consumer preferences. Disconnect between prices people pay and services received. So now we're going to discuss information problems and externalities that affect the market for healthcare. Remember, healthcare is this unique marketplace because it's not exactly a free market in the United States because there's government interference in it and it changes the prices. and health insurance companies are paying for it, not directly the consumers through. So there's all kinds of issues with that. The healthcare market is characterized by asymmetric information, a situation in which one party to an economic transaction has more information than the other. Again, in this situation, that's you. You have more information about your choices. This can lead to market failure and the inability of the market to maximize economic well-being. Two main forms of asymmetric information. Number one, adverse selection. One party elects to take part in the market or not based on their private information. So if I know I'm healthy, I may select not to have health insurance, which means the people in the health insurance pool are are more likely to use the insurance because they're more likely to sign up for the insurance. It's like sick people will sign up for insurance because they know they're going to use it, whereas healthy people won't sign up, which is part of the Affordable Care Act. Basically, in order to work, they need a lot of healthy people to sign up to offset the cost and pay for to offset the cost of the unhealthy people that are insured. And then there's a moral hazard. After engaging in a transaction, one party chooses different actions knowing that the other will bear some of the cost. For example, if I had to pay the full cost of potentially, let's say, diabetes treatment or something like that, and it was very expensive, I might make better choices eating because that's cheaper than the cost of this. But if the insurance company is paying for it and I pay $20, then it's more cost effective. I mean, it doesn't necessarily make a better lifestyle, but it's technically more cost effective to have the insurance company pay for it and me eat whatever I want than to do the other. Now suppose you're looking to buy a used car. Let's talk about adverse selection in the market for lemons. If someone offers to sell you a used car, you would believe the car is high quality and the seller just happens to want to sell it. Or would you believe that the car is low quality, considered a quote-unquote lemon, and the seller is trying to unload its problems on you? I would believe part number two. If you offer a moderate price, then only people with low quality cars will sell to you. So without further information, you don't want to buy a car from anyone who's willing to sell a car to you. Think about it. If you have a really great used car, are you going to sell it or are you just going to keep driving it? I don't want to belong to any club that will accept people like me as a member. Quote. Same idea. Health insurance suffers from similar adverse selection problems. The people who want health insurance are the ones who are likely to use it. Now, I don't know if that's 100% true. I'll also cautious people. So I know how much it could be if I was uninsured and to go into the hospital, thousands of dollars. And so I would prefer to have something more like catastrophe insurance. So I'm covered if any extreme illness, but for the general doctor visits, I could just use cash. That would be a better plan. So premiums need to be higher in order to cover the expected cost of all the people who are likely to use it. So therefore, if I'm signing up and I am healthy, I get stuck paying the premium someone who's not. But now people with only moderate needs may find health insurance too expensive, and then aka causing them to drop out. Might as well not buy it. The problem is lessened if people are very risk adverse, wanting to avoid risk. That's what I was saying. I'm risk adverse in the fact that I would rather have health insurance because with health you just never know. I could be walking and get hit by a bus or driving a car, so you just don't know. Health insurance companies have tried to lessen the impact of adverse selection by excluding pre-existing conditions. So that's no longer the case with the Affordable Care Act. You can no longer exclude pre-existing conditions. It is a normative value judgment question whether the gains for society through avoiding adverse selection outweigh the costs to society in the reductions in health insurance. So, an alternative way around this adverse selection problem is to mandate individuals to carry insurance. This is what we're doing now. Example, most states require automobile accident insurance. In 2010, the Patent Protection and Affordable Care Acts both introduced individual mandates to buy health insurance and restricted exclusions on pre-existing conditions. So the idea of a moral hazard in the health insurance. Moral hazard refers to the actions taken by people when they enter into a contract that make the other people worse off. People with car insurance might drive less carefully, knowing they are financially protected if they crash. That may be true, that may not be true, but it is more likely. People might use healthcare when they don't have to pay the full cost. Sure, I have a high deductible plan, and so I always talk about, it'll cost me $500 or $600. I have to pay the first, I think, $4,000 or something like that, $2,000, $4,000. And so I think about before I go to the doctor, but once I reach the deductible and the health insurance has to pay 100%, I might be more likely to go to the doctor at that point. So going to the doctor unnecessarily. Again, it's not everyone that does this. Personally, I don't like to go to the doctor unless I have to. Engaging in risky behavior. So am I out there skydiving? Am I out there? Did I not get vaccines? That's also engaging in risky behavior. Accepting excessive treatment options. You have to kind of question these things. If you had to pay for an MRI, are you going to question, do you really need the MRI? Such actions would increase the cost of healthcare to society, perhaps without providing substantial benefits. So the financial structure of insurance contracts may make doctors change their behavior also. Why? So again, in the United States, we can sue doctors for malpractice. This definitely drives up the cost. So they might order unnecessary tests and procedures in order to protect themselves from being sued. Another reason is to pad their expenses. If they get paid directly for those tests, that could be another reason. Since patients pay little pocket for additional care, they are likely to go with the extra treatment. This illustrates the principal-agent problem. The insurance company must delegate decision-making power to the doctor, who may not have the same interests as the company. Doctors tend to claim they don't order extra tests and procedures for financial gain, but either out of genuine concern for their patients or defensive medicine, which is to avoid malpractice. But if it were me and I was sick and I didn't know what was wrong, I'd want them to order every test until we figured it out, right? So who knows? The key to dealing with moral hazard is try to make sure people don't change their behavior too much. Patience. Deductibles. So if you've seen over time there's been a change. So it's either a much higher deductible or the patient pays for certain, like an MRI. You could have a $20 deductible to go to the doctor, but $600 for MRI. Coinsurance. The patient pays a portion of the treatment. This might be insurance company pays 80%, patient pays 20%. Doctors, they standardize payments for a particular illness. So therefore, no matter what they do, you get X amount of money for this illness. Such methods reduce but do not eliminate moral hazard problems. So other market failures, externalities. Recall that external costs or benefit will result in a market failure because from society's perspective, the wrong quantity will be consumed. Positive externalities. So one thing that's good in the market is vaccinations reduce the chance of others getting sick. Healthy population, good for employers. So if I'm healthy, that's better for employers. I take fewer sick days. Negative externalities, poor health choices like smoking or obesity. Now you're getting charged higher premiums for things like that. So should the government run the healthcare system? This is actually your first live debate. And I think it's a good one because people have very strong opinions about this scenario. If healthcare were a public good, that would be a strong argument for government involvement. Is healthcare a non-rival consumption or non-excludable? Neither of these seems likely, so healthcare seems to be a private good. You'll read about this in the chapter. So a non-rival, something that is our defense, so national defense. By people defending the country, by people defending me, technically I live here, it doesn't exclude my neighbor. But if a surgeon was performing a surgery, by performing that surgery, they can't perform it on both of us at the same time. So therefore, it is a rival situation. So the person who pays more or pays will get this or needs it more or something like that. They can't provide it to both of us at the same time. However, externalities and information asymmetries may be enough to generate enough market failure to prompt government involvement. Overall, the government's role in healthcare is controversial. So explain the major issues involved in the healthcare in the United States debate. So healthcare as a spending of GDP. So we talked about gross domestic product for the entire United States, and it used to be 5% or slightly above 5%, and we expect it to be over 15% by 2020. So healthcare spending. Now look at the United States. We're outpacing every other major developed country. High-income country, if you will. So the out-of-pocket share. At the same time, Americans are paying smaller and smaller portions of out-of-pocket. While the cost of healthcare is growing, and it's growing faster than any other country, in 1970, we used to pay 40% of our out-of-pocket costs. In 2010, we only pay about 15%, but that 15% is significantly higher. So why so much cost? Paperwork, malpractice suits, uninsured patients, so you're paying for other people. While paperwork is significant, it's not increasing fast enough to explain the rise in spending. I think paperwork's not it. Electronic medical record rollout, the initial upfront cost is more, but not long term. Malpractice, I do believe this. Significant cost. Congressional budget says 1% of economists estimate that as much as 7% of healthcare goes to malpractice suits. But again, not rising fast enough to explain the changes. Uninsured patients. Increase in cost of 1 to 4% due to getting it wrong, getting treatment in the wrong places. Like you have a cold and you go to the emergency room. Still not enough to exchange. What about the aging population? I think this is more likely. Advances in medical, keeping people alive longer, and the reduced birth rates. So the excess growth in cost and the aging population are kind of trending the same with each other. This is obviously growing faster. Costs are growing much faster than the aging population. This might also be to the ability for research. Service sector, cost disease. Service providers like healthcare have not seen huge productivity gains like manufacturing. Again, it's not like where I put a robot in and they are able to diagnose my healthcare problem. But in order to keep workers, wages have risen in this sector. In an ordinary market, we would expect demand to keep those cost increases in check. The problem with healthcare is, even if our income isn't rising at the same pace, we still may demand healthcare because it's a necessity. Health insurance distorts the economic incentives, making consumers insensitive to price. So remember we talked about elasticity. We're insensitive to price changes because the health insurance company is absorbing it. But not anymore, I don't feel, because with high deductible plans being the trend, we're absorbing more of that cost. It is still not obvious why these effects seem to be worse in the United States than other countries. The American system for private insurance has created significant inequality in access to health. While the health care for the rich is probably the best in the world in the United States, the same is not true for the poor. Extending health care coverage to be more universal has been attempted and rejected several times. In 1945 by Harry Truman, in 1993 by Bill Clinton. Each time Congress has denied the plan. In 2009, Barack Obama proposed significant health care reform by the PPACA, or also known as the Affordable Care Act or Obamacare. They approved the legislation. It should be fully implemented by 2019. It includes an individual mandate to obtain health insurance. And this is the only way it's going to work, because otherwise it's going to cost too much and only sick individuals are going to enter the pool. State health exchanges to increase access to policies. An employer mandate for most firms to provide health insurance. And this is really hurting some small businesses. Although the employer mandate is not the same for small businesses, it still affects people. There's a story in the chapter that talks about how for small businesses healthcare has been rising 20 to 25% each year. Regulation of the health insurance market, altering how health insurance companies can act. Expansion of Medicaid eligibility. So this is an expansion of who qualifies for Medicaid. But in Massachusetts, because we had a different level for income, it's actually going down. So the people that qualify will go down here in Massachusetts and up in other states. Medicare cost control. So they're basically limiting how much they're going to pay to doctors in Medicare situations. And increased taxes. So there's increased taxes on high income individuals and insurance plans. If you have what is called a Cadillac plan, so your company pays more than $20,000 for your health insurance, in 2016 you'll pay a tax on that. So be wary if you have good health insurance. The PPACA is expected to increase health coverage to 30 million additional people. CBO estimates that the increase in federal spending will be more or less offset by an increase in taxation. But now they're saying that that's not really true, so you got to do some research on that. Many economists have disputed these estimates, of course. Debate remains whether the PPACA is the right approach for America, or whether we should emulate other Western countries with more government control, or adopt a more market-based reforms, trying to reduce costs by making health care markets more like normal markets for goods and services. Remember, healthcare has a lot of government interference and insurance companies making it a marketplace where the true cost isn't very obvious and we're not sensitive to price changes. So, in a well-functioning market, competitive forces will help keep prices similar. consumers will shop around to find low prices, forcing high price firms to lower their prices. But that's not the case. So how much does an MRI scan cost? In New York City, the highest was $9,300 and $2,400. That's a huge difference. You go down to maybe Charlotte, North Carolina, and the difference is significantly less, only $2,400 between the highest and the lowest. Can you identify why this market is failing so badly? Purely because insurance companies pay it, so they're getting billed this, and so you don't make a decision to go down the street 5 minutes more to save $6,900, or you would do it if you were going to save it. With healthcare expenditures projected to consume almost 20% of the national income by 2020, we must find ways to reduce the cost. Out-of-pocket healthcare spending has gone down. The projected overall healthcare cost is going up. Whether or not politicians will find the way to do this is an open-ended question. Healthcare policy remains a heated debate, and that's why it's going to be your very first debate. So, common misconceptions to avoid. Adverse selection and moral hazard are forms of asymmetric information. These terms are similar and can be easily confused. So figure out which one is which, right? Provision and payment don't necessarily go hand in hand. The government can pay for healthcare without providing it, as in Canada. So this is the overview from Chapter 7. Make sure to read the chapter and answer the questions for homework.